very much importance right now. We are in the times of COVID, and we are all being bombarded with patients who have low oxygen saturation. We are being asked questions about when to supplement oxygen, how much of oxygen to supplement, through what device we should be supplementing it. And to speak with us on the details of oxygen therapy, we have with us Dr. SREEVALSAN TV. This session will be chaired by our very own Dr. P. Sukumaran, who was our former head of the Department of Pulmonary Medicine. Sir, I would ask you to please take over and begin the session with Dr. SREEVALSAN. Thank you.
Thank you, Suan. At the outset, I would like to thank Dr. Sankamitra and her team for having given me this opportunity to be back at home, because I always consider Department of Medicine as my own home, and I'm extremely thankful to you all for the wonderful thing, and congratulate you for having conducted this CME such a good one. Now, as Suhan said, there is no doubt this is a very important topic as far as we are concerned. And the topic is oxygen, elixir or poison, the pearls and pitfalls in oxygen therapy in hypoxic patients. What do we mean by hypoxemia or hypoxia? Hypoxemia is a decrease in partial pressure of oxygen in the blood, whereas hypoxia is reduced oxygenation at the level of tissues. It could be due to impaired delivery of oxygen to the tissues, or maybe defective utilization of oxygen by the tissues. Then clinically, hypoxia, we will define it as oxygen saturation of arterial blood less than 90% or a PaO2 less than 60 millimeters per mercury. It can be acute or long term, and most common pathogenesis are 5 types. One is decrease in inspired PO2, that is FiO2 is less. VQ by mismatch is a very important pathogenetic problem. Right to left shunt, impaired diffusion, and hypoventilation. These are the factors which will produce hypoxia. And what we do is, when there is hypoxia, we have to supplement oxygen, and there are definite indications should be there, and you should see whether there are contraindications. And remember, oxygen is a drug and it has got a therapeutic window. Oxygen dosage should be titrated as precisely as possible, and oxygen administration should be monitored closely with respect to clinical benefits and potential toxicities. So it is a drug burger. So you have to be very careful. And indication could be, as Suhan said, it could be acute, as in the COVID settings, or chronic settings. And we have got a lot of delivery systems also, like right from simple nasal cannula to venturi mask, non-breathing mask, oxygen mask with filters, high flow nasal oxygen, all those things. To talk about this, we have got a very eminent personality, Dr. SREEVALSAN, a pioneer of critical care medicine in Kerala. He has completed his MBBS from Government Medical College, Trichy, and has done his MD Anesthesia from Government Medical College, Calicut. He has a diploma in echocardiography, an MBA in hospital administration, PG diploma in quality management, etc. And he is currently the consultant and head of critical care medicine, LISIE Hospital, Kochi, and an accredited teacher for IDCCM and an assessor of NADH accreditation hospital. We are extremely thankful to Dr. SREEVALSAN. I have heard him earlier also in my own pulmonology seminars, and I'm very sure he will be definitely able to enlighten us on this topic. Over to SREEVALSAN, please. SREEVALSAN?
Yes, sir.
Okay.
Hope I am audible, sir.
Oh, yes.
At the outset, good evening, everyone. At the outset, my sincere thanks to Sangamitra Madam and Cyril for giving me an opportunity to be a speaker in this wonderful CME. And my thanks to Sukumaran sir for introducing me as well as the topic. Yeah, I'm here to talk on the pearls and pitfalls of oxygen therapy. We will start our discussion with refreshing our knowledge on the basic physiologic aspects of oxygen uptake and transport. We all know that oxygen is essential for the aerobic respiration, and one hemoglobin molecule can bind to a maximum of 4 molecules of oxygen. So if all the 4 binding sites of hemoglobin is occupied by oxygen, it is called 100% saturated. So in an arterial blood sample where we call there is 100% oxygen saturation, that means all the 4 binding sites of hemoglobin molecules are occupied by oxygen. And in the tissue, the uptake is decided according to the Fick's laws of diffusion, which, to put it very simply, that means that the oxygen diffuses across a membrane following a concentration gradient. That means it diffuses from the area of high concentration to the area of low concentration. So accordingly, in the alveoli, from the alveolar air, the oxygen diffuses into the pulmonary capillaries. And on the other end of the circulation, at the tissue level, it diffuses from the systemic capillaries into the cells. Now, a few words about the oxygen content and oxygen delivery. So we have seen that oxygen, one hemoglobin molecule can combine with up to 4 molecules of oxygen. So in that case, if all the 4 binding sites are occupied, that is, if it is 100% saturated, 1 gram of hemoglobin can combine with 1.31 ml of oxygen. So if you take the example of a person with a hemoglobin concentration of 15 gram per deciliter, that means he contains 15 grams of hemoglobin in 100 ml of blood. And if every gram combined with 1.31 ml of oxygen, the 100 ml of blood in a person with a hemoglobin of 15 gram per deciliter contain 15 into 1.31, that is approximately 20 ml. So 20 ml of oxygen is contained in a person's blood, 100 ml of a person's blood with a hemoglobin of 15 gram per deciliter. So that is what is meant by the oxygen content. Now, what is oxygen delivery? Oxygen delivery is the amount of oxygen that is pumped out of the left ventricle every minute. So if you take the same example in a person with a hemoglobin of 15 gram per deciliter, and if his cardiac output is 5 liters, that is 50 deciliters. So we have seen that 100 ml contains 20 ml. So in 50 deciliters, that is 5 liters, it would be 20 into 50, 1000 ml. So in a person with a hemoglobin of 15 gram per deciliter, and if his cardiac output is 5 liters per minute, and if his arterial blood is 100% oxygen saturated, the SpO2 or SiO2 is 100%, he actually pumps out 100 ml of oxygen every minute. So that is what is meant by the oxygen delivery. So oxygen content is basically what is contained in the blood, which is usually expressed as the content of oxygen in 100 ml of blood, whereas oxygen delivery is the oxygen that is carried by the blood to tissues every minute. So basically that is oxygen delivery is the oxygen content into cardiac output. So we have seen that 1000 ml of, in the example which I have quoted above, the 1000 ml of oxygen is pumped out of the left ventricle every minute. But in an average sized adult weighing around 70 kilogram, during rest, only 250 ml of oxygen is utilized. So which means only 250 ml out of 1000 ml, that comes around 25%. Only 25% of the oxygen that is delivered to the tissue is extracted at the tissue level. That is what is meant by the oxygen extraction ratio. So if you take this example, it is 250 divided by 1000, that is 25%. If you express this, it is a fraction, it could be 0.25. So if you take we all know that the arterial saturation of an arterial blood is usually 100% in a person with a normal lung. So 100% or 98 or 100, it is nearly 100% always in a normal lung. So if the 1000 ml is pumped out, if you take an SvO2, that is, if you take a sample of the mixed arterial blood, mixed venous blood from the right atrium or a central line, you can see that the SvO2 or oxygen saturation in the venous blood is 75%. So your arterial blood has an oxygen saturation 100 or near 100. And if your venous blood, mixed venous blood, has a saturation of only 75%. So that itself indicates that there is the oxygen extraction is 25%. the 100% saturated arterial blood and 75% saturated venous blood. So oxygen extraction is basically the oxygen extracted by the tissue from the oxygen that is delivered. So on a global scenario, that is 25% in a healthy adult taking rest. So what you see here is a pictorial representation of what I have told you so far. So in the x-axis, you can see the oxygen delivery. And on the y-axis, there is oxygen consumption of the tissues. So you can see here is a person taking rest. The oxygen consumption is 250 ml per minute. And the oxygen delivery is around 1000 ml per minute. Here you can, if you see, look at this graph, you can see that even when the oxygen delivery is coming down, the utilization of the oxygen is not actually compromised. So the tissues get the same 250 ml even when your oxygen delivery has decreased from 1000 ml to 800 ml or so. So how it happens? Because this happens because, so when the oxygen delivery is decreased, the oxygen extraction ratio proportionately increases. So we have seen that in a person during rest with a normal oxygen delivery, the extraction ratio is 25%. So it can go up from 25% to 30, 35 like that. So when the oxygen delivery is increased, the oxygen extraction ratio by the tissue increases so that the tissue demands are met. But this oxygen extraction ratio cannot go up beyond a certain frequency. Beyond a particular level, the oxygen extraction ratio cannot rise. So at that point of time, the tissues become deficient of oxygen. That is why we need to supplement oxygen. So in fact, there are several determinants of oxygen delivery. We have already seen that oxygen is carried by hemoglobin and it is taken to the tissues by the cardiac output. So oxygen delivery to the tissues are decided by three factors. One is cardiac output, and the second thing is hemoglobin, and the third one is PaO2, that is partial pressure of oxygen in the arterial blood. So how does the supplemental oxygen helps in increasing the oxygen delivery? So that is, out of these three factors, that is cardiac output, hemoglobin, and PaO2, we would be able to increase the PaO2 by increasing the supplemental oxygen. So why this PaO2 is important in increasing the oxygen delivery? We can see that the oxygen saturation of the arterial blood is proportional to the PaO2. If you look at this chart, you can see that if the PaO2 is 100 millimeters of mercury, the saturation of arterial blood will be around 100. So when you see that the SpO2, that is the pulse oximeter reading, which we see is a surrogate of this SaO2. So this you can read it as SpO2 as well, because in a normal situation, the SaO2 is almost equivalent to SaO2. So if you have arterial blood has a partial pressure of 100 millimeters of mercury of oxygen, that means the blood will be 100% saturated. And if the PaO2 is 80, the saturation will be 96. And the PaO2 of 55 corresponds to a saturation of 88. And if the PaO2 is 40 millimeters of mercury, that means the blood is saturated only 75%. So what is the importance of this PaO2 of, it's the PaO2 of 40. This is the partial pressure of oxygen present in the mixed venous blood in a normal individual. So if you take a venous sample, you can see that you might have noticed, all of you know that if you look at the venous blood gas, if you take a sample from the mixed venous blood from a central line and do a blood gas, you can see that the saturation is 75% in a normal individual. And the PaO2 of 26 means the blood will be only 50% saturated, and this is called P50. So out of these three factors which can actually determine the oxygen delivery, that is the cardiac output, hemoglobin, and PaO2, we supplement oxygen in order to increase the PaO2 so that the saturation of the blood can be increased or optimized. Now we have seen that the extraction ratio in somebody who is at rest or who is taking rest is around 25%. But that is a global scenario or an average number. That doesn't mean that each and every tissue extracts only 25% of oxygen. So if you look at the tissues, some of the tissues like heart and liver has a very high oxygen extraction ratio under normal physiological conditions. So actually the heart and liver extracts more than 50% of oxygen. And if you take some other organs like kidney and skin, the extraction ratio is much less. It is around 15% or 10%. So if you take all of these organs together, the average value will come around 25%. So what is the importance of this organ-specific tissue extraction? So we have to keep this figure in mind when we think of or discussing the supplementation of oxygen in different situations. For example, if you are dealing with a patient with an acute myocardial infarction. So if you take an example, if a patient, there is a compromised blood flow to a LAD or an RCX or some of the particular blood vessel, a particular area to the heart is the blood flow is affected. Suppose an anterior wall MI where the LAD is occluded. So if the blood flow is compromised by, for example, more than 60 or 80%, so the blood flow is compromised to that particular area into the heart, which means that the oxygen delivered to that particular part of the heart is compromised. So you know that it's already the heart is a tissue which extracts more than 50% of oxygen that is supplied to that particular area. So if the blood flow is compromised, so such tissues will suffer more. So that is the importance of supplementing oxygen when blood flow to a particular organ is compromised. In short, the organs which extract oxygen at a high rate during normal conditions suffer from oxygen deficiency earlier. So we have seen that this is the, I think by explaining the physiology, it is very clear that why we need to supplement oxygen to optimize oxygen delivery. So oxygen is the cornerstone of this aerobic respiration, which is very essential for the sustenance of life. What happens if the tissues are deprived of oxygen? If the tissues are deprived of oxygen, the body will switch into anaerobic respiration. The anaerobic respiration will result in accumulation of lactic acid as a byproduct, and the blood become acidic, and it is not the body and the organs and the body cannot survive beyond a certain point with anaerobic respiration. So if the oxygen supply is not optimized without much delay, that will result in cardiac arrest and death of the patient. So oxygen delivery is quite important. So if whenever the oxygen delivery to particular organ is compromised, that has to be rectified by appropriate measures. So oxygen delivery can be optimized by increasing the cardiac output. If there is an SP drop, hemoglobin has to be optimized by transfusing PAC cells. And if the PaO2 is less, that can be rectified by supplementing oxygen. So now we have, that is the importance of supplementing oxygen. So now, having said that, can oxygen be toxic? So in fact, Priestley, who discovered oxygen, he himself suggested that this gas, he described it as a pure air, oxygen. He described that oxygen as pure air. He himself felt that if you use the pure air, that itself could have some toxic effects. So in 1878, the person called Perlbert demonstrated that convulsions can happen in birds exposed to very high atmospheric pressure. So he subjected these birds to very high atmospheric pressure, that is 15 to 20 atmospheric pressure. That is the air compressed 15 to 20 times as that of the atmospheric pressure. So he found that when these birds were exposed to high atmospheric pressure, that could result in convulsions. And after 2 decades, Lorraine Smith noticed that fatal lung toxicity can happen in rats exposed to 4 days if they were exposed to a concentration of 73% of oxygen at normal atmospheric pressure. So these are the major organ toxicities that is described in human beings as well. That is the lung toxicity and the CNS toxicity. After these 2 pioneers who demonstrated this toxicity for the first time, these toxicities are known as Lorraine Smith effect. The lung toxicity is known as Lorraine Smith effect, whereas the CNS toxicity is known as Perlbert effect. Now, what are the determinants of oxygen toxicity? So it is generally considered that oxygen is not toxic if it is used at a concentration less than 60%. But that is not true 100%. That I will come to that in my later slides. But apart from, definitely there is proof that if you use more than 60% of oxygen beyond a certain time, that could be toxic to the lungs. But it is not only the FiO2. There are other factors which should also decide the toxicity of oxygen. That is the exposure time and the pressure, atmospheric pressure, that is atmospheric pressure through which the oxygen is delivered. So the pressure of the gas we breathe, the time of exposure are also important along with the FiO2. So we have seen that the CNS and the lungs are the major organs that suffer from the toxicity from the lung. So out of these two organs, the lung bears the brunt of the toxicity, the brunt of this problem. That is why it is, because the lung is the only tissue which is directly exposed to a very high FiO2. If you administer 100% oxygen or an 80% oxygen to a person, so whatever, even if suppose you are treating a patient with a severe ARDS, if you take the PaO2 will be very less because the diffusion is impaired, but the lungs are getting exposed to the very high concentration of oxygen. So 100% oxygen, so whatever be the PaO2, if for example, if you are take the case of a severe ARDS, so if your PaO2 may be only 50 or 60, but the FiO2 you may be using 100% oxygen. So the lungs are subjected to the higher FiO2 even when the PaO2 is less in a patient with a diseased lung. So the lungs are actually prone to develop the toxicity much more than other organs. So the reason for this effect is that lung is the air spaces of the lungs are directly exposed to high oxygen pressure. Now, why this is not happening to the other organs, including CNS? That is because whatever be your FiO2, the oxygen that is delivered to the tissues cannot go beyond a certain level. That is very evident from the formula which I mentioned in my very first slide. So oxygen saturation cannot go above 100%. So the oxygen delivered to other tissues cannot go beyond a certain limit. So lungs get exposed to higher FiO2, but other organs have this toxicity develop only when the high atmospheric pressure, they are subjected to a higher atmospheric pressure. So the CNS toxicity happens generally only during hyperbaric conditions, whereas the lung toxicity can happen in hyperbaric conditions as well as in normal atmospheric pressure if the FiO2 is high. Now the pathophysiology of oxygen toxicity in the lungs, it is caused by the reactive oxygen species. So reactive oxygen species are basically molecules containing oxygen with an unpaired electron in their outer shell. So if a molecule have, that is what is, if we have an unpaired electron in the outer shell, that is called a free radical. So the reactive oxygen species basically have oxygen molecules, so molecules with oxygen atoms with unpaired electrons in their outer shell. So these molecules are very unstable, and if their level, if it increases beyond a certain level, it can cause toxicity to the organs. It can damage lipids, proteins, and nucleic acid. So what happens to the lungs? What could be the what are the pathological changes that can happen in case of the high levels of reactive oxygen species? So the changes which happens in oxygen toxicity to the lungs are exactly the same as what happens in ARDS. There is hyperpermeability, hypercoagulability, and collagen deposits and fibrosis. And beyond a certain time, all these changes become irreversible. So the changes oxygen, which it's actually a paradox. We actually use oxygen to treat severe hypoxemic respiratory failure, including ARDS, but excessive oxygen, either in terms of FiO2 or high atmospheric pressure, can actually induce changes like ARDS in the lungs. So this we know that this reactive oxygen species are generally, it is commonly formed. It is formed normally in our body in certain amounts. We all know that the aerobic respiration that we all studied in our physiology days about this electron transport chain that happens in mitochondria as part of our aerobic respiration. So as part of this electron transport chain, the reactive oxygen species, including superoxide radicals and hydroxyl radicals with this unpaired electrons, normally are formed in the body. But there are systems, scavenging systems in our body which take care of this reactive oxygen species. We have enzymatic systems like glutathione peroxidase, superoxide dismutase, catalase, and vitamin A, E, and C, and other compounds like transferrin, lactoferrin, albumin, etc. So we have a scavenging system, enzymatic as well as non-enzymatic, which actually take care of this reactive oxygen species in our body. But when we administer very high concentration of oxygen, or when we administer oxygen at a very high atmospheric pressure, so the reactive oxygen species will be formed in very high quantities, and these antioxidant systems of our body becomes stressed. So these systems, when these systems are overwhelmed, that results in the oxygen toxicity. So we have seen that the second organ that is prone to develop toxicity to oxygen is the CNS. The CNS toxicity results in the seizures, and if it is not addressed appropriately, that progress to coma and irreversible damage to the brain. This is typically seen in patients who are subjected to the hyperbaric therapy, and in patients who are treated with the hyperbaric therapy, as just like oceanic divers, where we use this hyperbaric therapy to treat decompression sickness. So this is the EEG recording of a rat, which is subjected to 500 kilopascals of oxygen. 500 kilopascals means 100 kilopascals is 1 atmospheric pressure. So that means if, the pressure of the air, the oxygen that is subjected to this rats is around 5 times that of the atmospheric pressure. So that induces this EEG changes, that seizures, the seizure epileptiform activities are induced. And you can see that the third graph shows that it has after that is reversed when this hyperbaric oxygen therapy is discontinued. The EEG pattern is also reversed. So that is reversible if you identify and it is if you discontinue this hyperbaric therapy, that can be reversed. But if if you keep on continuing this hyperbaric therapy, there is a risk of irreversible damage to the brain. It is not clearly known whether it is caused directly by the reactive oxygen species, just like our lung toxicity, or some kind of a second messenger or some other intermediary molecules are involved. So having said that, is there a safe level of FiO2? What is a safe level of oxygen that can be administered to a patient without causing much damage to the body? So previously it was considered that it was important to maintain the PaO2, that is the partial pressure of oxygen in the arterial blood, as close to normal, that is around 85 to 110 millimeters of mercury. Now with extensive papers and studies from the ARDS net group, we all know that it is not the high concentration of oxygen is no more recommended. We all know that now the ARDS net group, that is they are the pioneers in releasing the guidelines regarding ARDS management. It is very clearly mentioned, they clearly mentioned that the target of PaO2 should be 55, which corresponds roughly to a SpO2 of 88. That should be the target, and never aim for a very high PaO2. Because if you are subjecting the high FiO2 is used to maintain a normal PaO2, that can cause more harm than good. So that is why in ARDS guidelines, it is recommended that the target PaO2 should be more than 55, not 90 or 100. So that is it. We know that the targeting normoxemia may cause detrimental effects to the lungs if you are using a very high FiO2. It is generally considered that oxygen is not harmful if used in a concentration less than 60%, but there can be untoward effect of moderate FiO2 levels as well. So in fact, if you are dealing with a diseased lung, just like an ARDS or a pneumonia, the threshold for developing toxicity is much less. So a patient with the ARDS lung is more prone to develop oxygen toxicity even at a lower concentration of oxygen. So we should be very careful in using the FiO2, whether you are using ventilating a patient, or if you are using a high flow oxygen delivery devices where more than 60% of oxygen is used. So we should be very careful in using the minimum possible concentration of oxygen to maintain the lowest acceptable PaO2, that is 55 millimeters of mercury, that is around 88, SpO2 of 88. But the clinicians frequently prescribe higher FiO2 levels than that is necessary to achieve their required arterial oxygen tension. So we have, we usually see in our clinical practice that many clinicians, by looking at the ABG, they say that the patient is, the PaO2 is only 70, so I increase the FiO2, which is not required. The PaO2 is 70, it is good enough. That's not going to cause any kind of an organ damage. So PaO2 is 70. It is okay to use if you want to maintain a PaO2 of 100. That is okay if you are using only 40% of oxygen. But if you are using a 70 or 80 or 100% of oxygen, your target should never be to achieve a PaO2 of 100. In that case, you should try to reduce your aim, your target to 55. The idea should be to use the lowest possible FiO2 to achieve the lowest acceptable level of PaO2. So we don't have much studies. We can, due to the reasons that are obvious, we cannot have some kind of an RCT to compare the toxic levels of Fi2, because we cannot subject human beings to high FiO2 or high barometric pressure to induce toxicity. So that kind of a study is not possible on ethical grounds. So much of our data is from the study from other animals. The study from primates, in a study that compared the oxygen exposure to primates, it was revealed that by day 6, 57% of the baboons and 33% of rhesus monkeys died by day 6 if they were exposed to 100% oxygen under normal atmospheric pressure. It is not a hyperbaric therapy. So 100% oxygen killed near more than 50% of baboons and more than 1/3 of the rhesus monkeys by day 6. So in another study done among human volunteers, when they were exposed to an FiO2 of more than 75% of oxygen exposure to a period of 24 hours has resulted in some kind of chest discomfort and cough in human volunteers. After that, it was discontinued because we cannot continue to expose a patient to demonstrate the toxic effects. And in another study, which actually looked at the pathological changes that happens in human volunteers after exposing to oxygen, they exposed some human beings for with just 50% of oxygen for nearly just 44 hours, that is less than 2 days. So 50% of oxygen exposure for less than 2 days actually resulted in changes of inflammation and impaired endothelial and barrier function of the lungs in less than 2 days. So apart from our contrary to our traditional understanding, it is not that you need a very high concentration of oxygen. The lower concentration of oxygen also can be toxic. So what we have to understand is that if you use a very high concentration of oxygen, the toxicity develops very fast. If you are using 80-100% of oxygen, the toxicity develops in less than 24 hours. If you are using 60% of oxygen, again, the toxicity can happen, but it takes a little more time. So if moderate levels of oxygen concentration can also be harmful if it is continued for a prolonged period, and very high concentration more than 80% can be harmful if for a very low period for 12 to 24 hours. These things we have to keep in mind. So in certain situations, we will have to use a very high FiO2. We know that when you are dealing with a case of a severe ARDS and or sometimes even with 100% of you may have to use an 80 or 100% oxygen to just maintain a PaO2 of 55 or 60. So in that case, you cannot reduce oxygen, but we should have an idea. We should be regularly reviewing, and at the earliest, we should be, once the patient's lung condition improves, we should be trying to reduce the FiO2 at the earliest. So we still do not know the minimal concentration of oxygen and duration of exposure that is sufficient to induce lung damage in normal human beings. And in some of the retrospective cohorts, which actually looked at the toxicity of oxygen in other disease conditions like stroke, MI, and COPD, it was found that the mortality was actually high when these patients were administered high concentration of oxygen for beyond a certain period of time. So these are some of the Sukumaran sir has mentioned in his introductory talk regarding the different oxygen delivery devices. I'm not going into the details of different oxygen delivery devices. What I have shown here is some of the high flow oxygen systems, which actually deliver more than 80 to 100% of oxygen. This machine view, this oxygen delivery device, everyone will be familiar. That is a non-rebreathing mask with a reservoir bag. And this can theoretically provide up to 100% of oxygen because there is a reservoir and there is a unidirectional wall which from the reservoir back to the oxygen mask. So, but in many situations where, if especially when the patient's flow requirement is very high in somebody who is breathing at a rate of 30 or 35, with an excessive, in a patient with a air hunger, where there is the airflow requirement is very high, this 100% oxygen saturation can never be, 100% FiO2 can never be achieved in this equipment. But in somebody who is not breathing quietly, it is possible to achieve nearly 100% of FiO2 even with this non-breathing mask. But this is with this COVID epidemic and all, now we all, I think most of you are now by this time familiar with this high flow nasal cannula. And this is one particular oxygen delivery device. Even though it is not very new, it is a new device, but it's not very new. It has been there for more than a decade. But this particular delivery device has become popular across the globe during this pandemic of COVID-19. And I know that by this time, most of you are using this. And unlike this non-rebreathing mask, this HF flow nasal cannula device can actually deliver nearly 100% of oxygen, because this can meet a very high oxygen flow requirement. The flow meter of this equipment, you can set an oxygen flow of around 50 liters per minute. So even when the flow requirement of a patient is 50 or 60 liters per minute, you can actually achieve the FiO2 of 100 or near 100. And unlike the case with a non-rebreathing mask. Whereas in the non-rebreathing mask, the flow, you know that the normal flow meter, you cannot increase the flow more than 15 liters per minute. So if somebody who is breathing more than 30 with a tidal volume of 500 ml per minute, their actual flow requirement will be some 40-45 liters per minute. So so in such situations, this NRBM will not actually provide this 100% oxygen. But HFNC can provide nearly 100% of oxygen. Now we deal with a lot of patients with the COVID, patients directly coming with the COVID pneumonia with happy lung, but it's the happy hypoxia with a patient without any distress, but severe hypoxemic respiratory failure. And some of the patients, now a lot of patients have started to get admitted in hospitals with a post-COVID lung. So they are the patients who were actually treated at home or at a first-line treatment center. Their antigen becomes negative and they become asymptomatic and get discharged. And after 1 or 2 weeks, they come back to hospital with breathing difficulty. And they show very severe hypoxemic respiratory failure. I am sure all of you must have seen so many cases by this time, because it is a pandemic and it is everywhere. So in such situations, the problem is that unlike a normal pneumonia, normal bacterial pneumonia, this situation never gets better. It gets, these patients keep on, they will be kept on this high flow oxygen delivery devices for weeks or months together. So we have to keep it in mind that what the therapy we offer for this patient with the hypoxemic respiratory failure can in fact can be harmful, at least in some patients. So we have, I have personally seen patients who actually use this HFNC for 2-3 weeks or more than a month, and finally they deteriorate. So at least in some of these category of patients, the oxygen, high concentration of oxygen could be the culprit. But if somebody is severely hypoxemic, I do understand that there is no other way than to use a high flow oxygen device. But whenever if the patient's condition improves, we should accept the lowest acceptable SpO2. So if we are not supposed to provide somebody with supplement 80 or 100% of oxygen to maintain an SpO2 of 100. That is the main mistake which many of the clinicians make. So you just, the oxygen FiO2 should be titrated in such a way that your SpO2 is acceptable level. It is somewhere near to 90 will be more than enough, especially in a patient who got used to low levels of oxygen levels. So some of the practical points on oxygen therapy, we have to remember that accepting a PaO2 of 55, which is enough to maintain an oxygen saturation of more than 88, will be enough in most of the clinical situations. And in patients who are on mechanical ventilator, we can use the strategies like usage of higher PEEP and techniques like inverse ratio ventilation to reduce the FiO2. So these are some of the using of the higher PEEP and inverse ratio ventilation are some of the interventions that can help reduce the FiO2. because these are the things which actually improves oxygenation. The inverse ratio, I hope everyone knows what is meant by an inverse ratio ventilation. In normal physiological conditions, the IE ratio is around 1:2. That is, expiratory time is double that of double or more than double that of inspiratory time. So when you set the inspiratory time at least equal to or more than that of expiratory time, that is 1:1 or something like 1.5:1 instead of 1:2, that is called an inverse ratio ventilation. So inverse ratio ventilation and the use of optimal PEEP can actually help in reducing the FiO2, because this higher PEEP can actually help in recruiting the lungs in managing a patient with this ARDS. Not every patient will respond to a high PEEP, but a significant number of percentage of patients with the ARDS will have some kind of recruitability. If you use higher and higher PEEP, you can see that you can, if you are, suppose you use an 80% oxygen and PEEP of 5, and if you increase a PEEP to 10 or 12, you will be able to see that the FiO2 can be reduced from 80% to 60%. So that happens if you somebody who is managing ventilators, managing ARDS and ventilators, I'm sure are aware of these facts. And now other things which are important in reducing that helps in reducing the FiO2 is avoiding the patient ventilator desynchrony. In a patient with a severe hypoxemic respiratory failure, in a severe ARDS with a PF ratio of less than 100, it would be difficult to ventilate the patient if you don't sedate the patients, because there could be, suppose they put a patient who is breathing spontaneously, who is not sedated well, there will be some kind of a fighting. There could be a desynchrony. And if you put a patient on an inverse ratio ventilation of 1:1, that is something the body is not used to. So body will always try to get back to its normal physiological phenomenon. So that is, there could be some kind of a desynchrony with the ventilator. That patient ventilator desynchrony always happens when you are ventilating a patient with the inverse ratio or in a severe ARDS. So to avoid or reduce the patient ventilator desynchrony, you may not be able to totally eliminate it, but at least we can reduce it, or you can reduce the amount of the desynchrony. That can be done by increasing the level of sedation, appropriately sedate the patient. And if patient is still fighting a ventilator, you will have to administer muscle relaxants. So at least for the first 2 days of initiating mechanical ventilation in a patient with a severe ARDS. And other strategies which can help in reducing oxygen therapy, that FiO2 is going for a conservative fluid strategy. If you are managing a severe hypoxemic respiratory failure, if you, one of the main cause of ARDS, that is sepsis. There's pulmonary, it is a pulmonary sepsis or some other extra pulmonary sepsis. It could be from a pneumonia or some other sepsis. Sepsis is one of the major reason for development of ARDS apart from trauma and all. So this, in such situations, there is a landmark trial published by the ARDS Net group a few years back. There is a fact trial. That is, they have clearly shown that if you reduce the positive fluid balance, if you use a conservative fluid strategy rather than a liberal fluid strategy, actually you can reduce the days on mechanical ventilation, and that also improves the mortality. The situation is, we know that the patient comes, suppose there is take a case of a pneumonia, a patient comes with a bacterial pneumonia, goes into sepsis, septic shock and other organ dysfunctions, and during the initial phase, we pump in a lot of fluids, because that is part of that's a cornerstone of the sepsis resuscitation. We pump in fluids, literally 3-4 liters in 1 or 2 hours, and continue at the 150-200 ml per hour. So if you, some of the patients will be having AKE as well. They will be having a high dose of noradrenaline. But once, if the situation is under control, but if you find that the patient is now, after 2 or 3 days, you daily assess the positive fluid balance, you find that there is significant positive fluid balance. It is not uncommon to see a patient who has been resuscitated from septic shock to have a positive fluid balance of 8 or 10 liters on day 3 or 4. It is quite common. So if you take care of it, but that is initially you have to resuscitate, that is a part of the resuscitation. But after attaining the hemodynamic stability, you will have to go to the concept of de-resuscitation. There is a concept that is called a de-resuscitation, which is just opposite of fluid resuscitation. So you resuscitate in the beginning, and if there is that results in significant positive fluid balance, that extra fluid has to be getted off. So that can, if that positive fluid balance is avoided, That can be that you can, if the patient's renal function is normal, you can try diuretics. And if that is not possible, you can even do ultrafiltration to remove excessive fluids once hemodynamic stability is attained. So this is this seems to be some of these things are not practiced very commonly, but it is very, if you do practicing these things, you can realize how important these things are. So it is not, when you talk about FiO2, reduction of FiO2, it is not just the oxygen, and it is not something to do with the lungs and all. It is other things that fluid balance is a very significant thing that could contribute to the decrease in the oxygenation. And in severe oxygenation impairment, in severe ARDS, the resorting to extracorporeal membrane oxygenation, extracorporeal therapies can actually help in reducing the FiO2, because oxygen level can be increased using extracorporeal circulation through extracorporeal methods, so that your and the lung can be ventilated with a very small tidal volume, very low tidal volume, and acceptable FiO2 of 40 or whatever is acceptable. So these are some of the practical points which we have to remember in managing patients with a severe hypoxemic respiratory failure that would help in reducing the FiO2. To conclude what I have discussed so far, oxygen, we all know the gas, it is a gas that is vital to sustain life, but it has the potential to destroy it as well. And the rise in inspired oxygen concentration and increase in the environmental pressure, or a combination of both, can lead to toxicity. Lung toxicity can occur with a high FiO2 at normal atmospheric pressure or under hyperbaric conditions, whereas the CNS toxicity generally happens only in hyperbaric conditions, because the oxygen, the quantity of oxygen, the amount of oxygen that is delivered to the central nervous, to the brain, cannot go just by increasing the FiO2. So that happens generally in hyperbaric conditions. And in preterm babies, especially with a low birth weight, small for gestational age babies, the retinopathy is an additional complication of oxygen therapy. So this is, I just Googled the definition of a poison. So this is the definition which I got from a medical dictionary. Any substance that can cause severe organ damage or death if ingested, breathed in, injected into the body, or absorbed through the skin is a poison. So in that sense, oxygen also can be a toxic. It can be a toxic substance or a poison. And if you ask me the question whether oxygen is good, bad, or ugly, the answer is it could be anything, depends on how we use it. Thank you.
Thank you, SREEVALSAN, for the excellent narration of the story. And there are a lot of questions now. Can you hear me, SREEVALSAN?
Yes, sir. Yes.
Okay. So there are a lot of questions, but due to paucity of time, maybe Dr. Sankamitra has said we can take 3 or 4 questions. What are the absolute contraindications for oxygen therapy?
There is no contraindication for oxygen therapy as long as we are we are not going above this FiO2 or a PaO2. That we have to. That as long as you are using something, 40% oxygen is generally not toxic, even if you continue it for an indefinite period of time, as per the information data available as of now.
Yes, because there is no absolute contraindication. There is only relative contraindication which you should see. Only thing is you have to see the partial pressure of oxygen is maintained at that level, isn't it? And there is another question: what is Bird-Smith effect seen on hyperbaric oxygen therapy in patients? You said hyperbaric oxygen produces, no doubt about it, no?